See so many people joining us. As I said earlier, my name is Jen Kenwood. I'm the Experience of Care Lead for Community Primary and Integrated Care at NHS England and the National Lead for our Carers programme. So I'm absolutely delighted to welcome you to this month's Lunch and Learn session. Just in terms of housekeeping, obviously it's a short session and we have lots of people on it. So if you can, as you join, introduce yourselves in the chat box, that would be great. So we get a sense of who's here with us. Everyone is very welcome. Really appreciate, particularly given everything that's going on with COVID and pandemic responses, a number of you giving your time to join us. So thank you for that. I'm going to be handing over shortly to Jodie from East of England, who is our regional lead for the Carers programme there, and she'll be introducing our speakers for today. But just to say, because it is limited time, if you can put questions that you have in the chat box, what we will try to do is come to those at the end, and I try and keep a running record of questions as I see them so that we can try and summarise those for our speakers at the end, but it gives them hopefully a good opportunity to share their experiences with you and their stories with you. Steve, sorry, could you just get back to the agenda for a moment? Thanks. So as you can see, this month we have representation from the East of England. What we're trying to do with these sessions is really uncover and share with you stories of success, innovation, and progress with work around identifying, supporting and improving outcomes for unpaid carers all around the country, and trying to avoid always telling the same stories from the same places. So huge thanks to Jodie, our regional lead from East of England, for inviting our speakers today from Norfolk to join us. Really great to see something different actually, and something I know very, very little around in terms of social impact bonds. So really exciting opportunity for all of us, but particularly me, to learn something. And Jodie, I will hand over to you to introduce your colleagues.
Thanks, Jen, and thanks for everyone for joining today. I always like to say in the East of England, we like to do things differently and uniquely, and I think this is an example of one of this, of how unique we are. So I'd like to introduce Bethany Small. She's Commissioning Manager from Norfolk County Council. James Stewart is the operational business lead for adult care in Norfolk County Council. Vicky Jones is the Program Director for Bridges, and Lucinda Richards is the Investment Manager for Bridges. So I'll hand over to these four, and I hope you enjoy as much as what all the innovation that they're doing. Thanks.
So I believe it starts with me. So my name's Bethany Small.
Will you stop it?
I'm a commissioning manager with Norfolk County Council, with responsibility for commission services for our adult carers caring for adults. So we have prepared some slides, Helen, if you don't mind moving on to those. So we wanted to start the presentation with just to look at why Norfolk chose to pursue an outcomes contract. It says why now, I guess, because we're 1 year on to that contract now. So really it's about why then, and then some of the kind of first year lessons we've learned in terms of how the contracting process has gone, because there are other social outcomes contracts in Norfolk County Council, but I believe this is the first one, well, it's certainly the first one we've run for carers, and it's the first one that I've worked on also. So if we move on to the next slide. So when we were looking at our care services, there was a number of things that we felt weren't really working very well for us. So at the time, there was evidence that we were doing fewer care assessments than we had done previously, and that the care assessments often resulted in additional support to the cared for person rather than to the carer, and that was an increasing trend. You could see we were doing fewer assessments, and the money being spent into the cared for person as a result of those was going up. So our support, our assessments weren't really hitting support directly to the carer. Also, we knew that carers were increasingly unhappy with our services, so our survey of adult carers in England outcomes were on a downward trend, and had been across at least 3 well, 6 years, so 3 surveys, and we also fell below national and regional averages on the scores that we were achieving. We did have a carers break offer. It was accessed by a few families, and those families really valued the offer, but it wasn't. It was very few families of the numbers that could have been benefited from it, and some of those carers breaks have been going on for 3, 4, 5 years, so at that point had become kind of replacement care, a general home support package, rather than a short time limited offer to the carer. And to get any of those services, you had to go through quite a lot of an assessment. There was a big assessment ward in the council, and so there's nothing we could offer you without doing quite a significant amount of assessment on you. So we'd identified that there were some problems with our offer that we weren't pleased with. Go to the next slide. We'd also identified some stuff that we thought we were doing really well. So there was evidence that that we were supporting carers well through our Carers Matter Norfolk service. And so that was a contract that we commissioned to do to get early information and support and advice to carers before they needed a carers assessment. So really early advice and support, and that was going. Carers were benefiting from that service. We had a really well established carers emergency card offer, so carers could sign up, register a plan with the council, and if they had an emergency, which meant they wouldn't be able to do their caring role, or if they were in, for example, in a road traffic accident, our emergency responders were trained to look out for that card and put the plan in action to make sure that the cared for person received support. There was evidence that we were then kind of linked to that evidence that we were able to react quickly in an emergency. So where the care was breaking down or where the carer couldn't care for reasons, there was evidence that we were able to react quite quickly to that emergency situation and put things in place. And there was good transparency with carers, so we had quite a good relationship with our carers and were able to kind of build trust with them. So, for example, when we identified all the things that weren't working well for us, we were able to take that to our Carers Voice partnership group and talk to them about what wasn't going well and what we wanted to do instead. And carers felt there was good transparency from the council on that. So we knew it was working well, we knew it wasn't working well, and we needed to do something different. So we go to the next slide. So the something different we decided to do was move towards an outcomes contract model. And so we also refer to it as the social impact bond. So a social impact bond and a social outcomes contract are essentially two different names we're using for the same thing. So why did we go for a social outcomes contract model? So there was an opportunity to work with the Life Chances Fund and work with Bridges and in doing that work we were able to look at our service offer and pathway with fresh eyes. It was bringing different people into Norfolk and people with different experiences and backgrounds and skills to look at our offer with a fresh pair of eyes. It also gave us access, working with the Life Chances Fund to build the outcomes contract model, also gave us access to consultancy, external consultancy, who had expertise in outcomes contracts to help us develop our model. There was an ambition in Norfolk overall to move our commissioning to an outcomes-based commissioning model, and this just got us there much more quickly. This was a crash course in outcomes-based commissioning, and there is a laser-like focus on the outcomes. So that just enabled us to move towards the outcomes model much more quickly. Of course, working with Bridges and having an organisation with Bridges' experience gave us a lot of confidence in their contract management skills and in their ability to steer the outcomes contract for carers in Norfolk. And what didn't hurt was that working with the Life Chances Fund gave us quite a large amount of additional funding, and so that allowed us to be very ambitious. Also to turn the corner from where we were with carers assessments, and where we had a model that was saving us as much money as it was costing us, we think is going to take us between 4 and 5 years. So having the additional funding from the Life Chances Fund to allow us to run the contract whilst not seeing the savings until years in the future, just allowed us to be a lot more ambitious and test a much more ambitious model. It also allowed us to bring on external evaluation of the overall model. So I can see some people on this call that are part of our comparative authorities group, and that is run with the Institute of Public Care. So we've got the Institute of Public Care alongside everything we're doing, externally evaluating the thesis. So the thesis of the contract is that by supporting carers in this way, we will reduce carer breakdown, and that will save the council money in the long run. And what we've been able to do is get the Institute of Public Care on side to either prove or disprove that thesis. So that's been really helpful. So I think I probably should just explain what the Life Chances Fund is, because I realise I skipped over that bit. So the Life Chances Fund is lottery community funding, so through the Department of Culture, Sport and Media. So the Life Chances Fund fund social outcomes contracts across the country, and what they offer is they pay part. So when an outcome is achieved, we pay the service, and the Life Chances Fund pay a percentage of that outcome for us. So it's quite a significant amount of funding that they give us to deliver this social outcomes contract. So yeah, of course, there was kind of access to money, access to consultancy, access to expertise, and it was allowing us really quickly to move towards an outcomes-based model, which had been our ambition overall. So that's kind of why we wanted to go with an outcomes contract model for our carer service. Kind of the timing and the opportunity aligned really well for us. So a year on, what have we learned about using a social outcomes contract? Next slide, please. So what have we identified? The emphasis on outcomes and the focus on the outcomes means that we've been really able to identify where parts of the service that we were previously delivering weren't serving our aims for carers in Norfolk. So if something's not helping us achieve an outcome, why are we doing it? The outcomes are our aims for carers in Norfolk, and so all the work that we're doing needs to be taking us towards those. And so it allows us to find what's extraneous and then refocus our effort and resource elsewhere on something that will take us forward. It has also meant that we need to think more carefully about when we want to commission additional services through the contract. So with a previous contract where there's kind of we'd write a spec, we'd be very detailed about what we wanted to be delivered and how we wanted to be delivered, and we'd give that organisation some money, and we'd pay that money quarterly, and they do the things for us. When we wanted them to do something new, we could fairly easily just add it into the spec, add the extra bit of money, and that contract was done. Now, when there's been, and as you will all be aware with COVID, there's been lots of different short-term funding opportunities that have come up. You can't as easily in a social outcomes contract just write it into the spec, give them the money, and there you go, because the spec is the outcomes. The spec isn't the way the work should be done. And so we have done it successfully. It just required us to think in a different way and actually communicate and collaborate with our providers much more. So I think that's been a beneficial outcome, but it was a bit of a surprise the first time we tried to do it. What we have experienced is that Bridges are really keen to understand the optimum delivery model for the service, and really keen to use evidence to develop their new ways of working. I think that's a benefit, again, of having the outcomes, having a social outcomes contract, is that your provider is then really both kind of empowered and enabled to understand the optimum delivery model for the service, and that can only benefit carers long term. In having an external evaluator, after year one, they have done us a year one report, and what they've done is helped highlight both where the contracts worked well. There's been some real benefits to the contract even in the first year, but they've also identified opportunities to improve how we're measuring our outcomes and how we understand success moving forward. And I don't think that's necessarily detail we would have come to this quickly ourselves. I think having that, again, that external evaluator who's trying to help us evidence our thesis has been really beneficial, even in year one, to make sure that the outcomes that we're working towards are still helpful for us, but also the way that we're measuring those outcomes is benefiting both us and also beneficial to the experience that carers get through the service. We've also seen better service user involvement. So we have a carers voice organisation in Norfolk that's done lots of work with this and is part of this contract, worked really well for a number of years. But what we're seeing in the new service is with Bridges' involvement, again, their experience and learning involved, is that we're much more able to access the experiences of carers who've just received Carers Matter Norfolk service, who've just received a service through the social outcomes contract, and use that to then improve very quickly what the offer is, and we're experiencing that much more so than we had in the previous contract. So I think we're really excited about the possibilities and how that's going to support service development moving forward. What I would say is we've set the contract out as a 5-year contract, and we have this is kind of our learning from year one. So some of the learning is, obviously it's very early on, we're kind of 20% through what we're trying to do. So this is our very early learning on it. But I think already it has been a really interesting, and I hope my colleagues will echo this in the rest of the presentation, it's been a really interesting and beneficial experience, certainly for us as a council running a service in this way. So I think with that I hand over to, is it Lucia?
Yes, thank you, Bethany. I noticed that there are a couple of questions in the chat. I wonder if I quickly answer them before I go to my section. I see that Kate said...
Can I interrupt, it's Jen here. Can we keep the questions for the end?
Okay, yeah, of course.
Then we make sure we get maximum time with you guys.
Absolutely, no problem. So if we can go to the next slide, I'm gonna just very briefly kind of try to explain what an outcomes contract is. Hopefully some of it has already come across from Bethany, and then Vicky will bring it to life with the carers example specifically, and I think some of the questions in the chat will be answered on her section. Sorry, this slide has pop-up, so maybe you can just click through it until everything shows up. So I thought I'll explain what an outcomes contract is by using an example from another service, which is a rough sleeping service that we support in Greater Manchester. As Bethany has alluded to, I guess the reason why outcomes contracts exist, or I guess their ultimate purpose, is to try to support people that for whom public services might be failing, despite them being in contact with them. And so this is the case of a real person that we supported in our rough sleeping service. We call him Steve, that's not his real name. He had experienced childhood trauma when he was growing up, had been into local authority care, he didn't finish his education, had interacted with the criminal justice system, and did no longer have a support system around him. And so that meant that a few years later in his life, Steve had been rough sleeping for 10 years. He had no ID. He was unemployed. He had criminal convictions. He had addictions, mental health problems, and was not able to house himself. And so if we go to the next slide, please. And again, click through. Really sorry, I should have taken this animations out. And so there were a number of services, as they're popping up in the screen, that Steve had interacted with, but these services were not meeting his needs. So he was not eligible for welfare payments because he didn't have identification. And part of the reason for that is that if he had identification, he would likely be convicted for his previous offenses. He had struggled with different types of accommodation, so he was not being allowed in either hostels or social housing. Nobody wanted to give him a chance in terms of employment because he seemed too hard to employ. Addiction services require you to have kind of some ability to go there yourself, and he didn't have a support system to manage that. And he was not able to access mental health services because even though he had mental health issues, he didn't have a diagnosis. And so if we go to the next slide, I guess what this next slide tries to explain is what an outcomes contract does to shift that paradigm. Instead of looking at all these little problems individually and trying to patch them each, you look at the long-term outcome that you're trying to achieve for this person. So for this service, it was achieving housing that would be stable and that they could sustain, and hopefully also employment for these people. And so what we did was kind of change all of that. And what I guess how the outcome contract achieves that is that by, as Bethany said, instead of focusing on a specification of you should do this and that, you just focus on the outcome. And then as a provider, you have complete flexibility to bring ideas and try different innovations that might help you achieve that ultimate outcome. That tends to generate a lot more innovation than you see in other services. It also forces more collaboration between different parts of the system that normally are more fragmented. And that's all allowed because you ultimately have the outcomes that holds you accountable to what you're trying to achieve. And so if you go to the next slide, what you'll see there is that for Steve, again, click through to get all the pop-ups. For Steve, we were able to get him identification. Instead of going into the criminal justice system, we negotiated with the system that if someone was in the program, then they wouldn't need to be convicted and would get a second chance. So they were able to continue kind of progressing on their journey. We negotiated with social landlords to oversee the rent arrears that didn't allow them to use that housing anymore so that they could be housed. Once that they had this basic support, you were then able to help them connect them back to their GP and get their health back in order. One of the innovations was to actually hire a dual diagnosis nurse directly into the system so that everybody could have a diagnosis and then they could access the mental health services. And eventually all of these people were supported to try to see if they could find employment. And so what the next slide shows is in terms of what this achieves in practice. And I guess what we try to say is that an outcomes contract delivers better value for money than a typical fee-for-service contract. And so as you can see in this slide, our initial target in this contract was to house 183 rough sleepers. We actually housed 357 of them. And that equivalent, the cost per person housed was £7,000. Now, when we compare it to similar rough sleeping programs in other parts of the UK, these are contracts that were on a fee-for-service basis, and so they didn't have this incentive to achieve the outcomes and to try to get as many people as you can. And so across them, you can see that the resulted cost per person house was much higher at 25,000 per person. And just two last points in the last two slides is that I guess what are the key things that you need to make this happen. One is having great delivery partners that want to work on this way. We've worked with, I think, almost 200 different delivery partners across the UK in all of our contracts, and they're generally all very motivated and happy to have the opportunity to be more flexible in the way that they deliver the services. And and we have managed to achieve great things with them. We've just put some examples on this slide. And then the other thing that you need, which is on the next slide, is obviously a commissioner that is willing to try this new way of working. As Bethany said, it can be a bit daunting at the beginning because it's quite different from traditional commissioning. But what we have seen is that once a commissioner tries this, they normally do more of them. And as she said, in Norfolk, they've already done 4 different outcomes contracts. But you can see in this slide that many other councils who have tried it have also repeated. So now I'll hand over to Vicky, which hopefully will give you a flavor of how all of this translate into the carers contract.
Thank you, Luthia. I did see some quotes in the chat. I think what Luthia's aim there is to understand the basis of what an outcomes contract is, and I'm going to come and evangelise and talk about the exciting stuff we've done in Norfolk. So if you move on to the next slide, please, and I will get cracking. So just our year 1 in numbers, a very dry slide. We've seen nearly 3,000 carers come through. 1,500 have been triaged, 813 have been assessed. There's been a fairly even split between low-level support and intensive support. So our low-level support is provided by our staff members on the advice line, and our intensive support is one-to-one support in the community, albeit the C word, COVID, that has slightly skewed the number of people who get to be seen face-to-face, but it's a much higher level of intensive support. So health and wellbeing grants, we've spent nearly £10,000 in year 1. 729 hours of breaks, which again has been impacted by COVID. And we've also loaned out 33 tablets on our tablet loan scheme to get people online during the pandemic to make sure they're receiving as much support as possible. I'm not going to go through the other numbers. If we quickly whiz through to the next slide. Okay, so the way previous service was structured, Norfolk provided the carers assessments themselves. It was a fee-for-service contract, so they designed a specification and the delivery partners then were contracted and they delivered it to specification. The way we run this service now is through the outcomes contract, and we focus on the outcomes. So Norfolk don't tell us how to run the contract, they tell us what they want to achieve. So this is a slightly different structure, but we have oversight of all the delivery partners on this contract, and we work together with them. If we move on to the next slide. So at Bridges, we work on 3 main principles. Now, the first one, this is really important, and I know Bethany's alluded to it already. It's collaborative design, because basically we want to achieve these outcomes for carers. Now, I'll just go through what these outcomes are. Bethany's already mentioned that we want to prevent carer breakdown, which is the first one, but it's really pleasing when we came into this contract that Norfolk have actually taken this a step further, really forward thinking. They don't just want to prevent carer breakdown, they want to improve carer well-being, which is a really, really positive step and really gives us something great to work with. The other outcome is to identify new carers, and I can tell you from the number of referrals that we receive month on month, we are definitely identifying carers who previously wouldn't self-identify. So in terms of collaborative design, designing for the service from the very outset involved carers, staff, people internally, externally, professionals, and we look to work within an asset-based model as well. So that's including all members of the community to bring their skills into play into supporting carers in our communities. So Bethany again has talked about the co-creating service. Now, previously with the service that we inherited when we took on this contract, a lot of the consultations are done with very specific groups of carers who have been involved for a very, very long time in sort of a piecemeal way. So we ask a question, we get a response, but there was no way of feeding that back in. It was almost a very stayed, stuck approach where we'd ask a question, they'd give us a, and we'd go away and do things, and it would disappear into the ether, and nobody heard about this again. I'm really pleased to say that we are now working with Norfolk. We're avoiding duplication of these consultations. We've got a much more thorough way of engaging our carers, and that's through informal means when they talking to our frontline staff who feed back in. It's through the more formal consultations. It's through social media, it's through the traditional meetings. We've opened up every avenue we can, so we're really, really listening to our carers. The other ways that we do this is we also use data I'll come on to the data part very shortly, is carers not only tell us what they want by what they say, they tell us what they want and what they need by the way they behave. If they're not accessing a particular part of the service, then that's on us. We need to ask the right questions. Why isn't this service being accessed? What do we need to do to support this and to make the change for the better? And that's something that's working really, really well in Norfolk now, and we're working very, very closely with Norfolk County Council. So this one, I'm sure will be familiar to everybody. It's bringing different departments together for a more joined up approach. Now, in the voluntary sector, we all know it's a really, really small sector, and we are bringing together, and I'm going to use this term, is natural enemies, natural competitors. Whereas people have been very siloed before, everybody's going for the same pot of funding on numerous occasions. So actually, there's a lot of politics with a small p in these communities, particularly around caring. And what we've aimed to do is having this focus on the outcomes, what's best for the carer, has enabled us to bring everybody together to say, these are our carers. These carers don't belong to one organisation or another, and we all work collaboratively to achieve these outcomes for the carers. So we have cross-organisational project teams, so we don't work on things in isolation. We really bring everybody in, and that's including carers too, to talk through what our challenges are and identify innovations or sometimes just really simple solutions to benefit the carer. So I'm going to very briefly touch on, we have our commissioner, Bethany, who sits on our board meetings, and we treat our commissioners more like a partner. So it's a very relationship-based contract. So everybody has the opportunity to input into it, everybody's ideas are listened to, rather than sort of the more old school transactional contracts. Okay, we'll whiz through to the next slide. Thank you. So flexible delivery. We can move very quickly on anything that we do. We don't have to go through the normal process and channels of changing a spec, because everything is to do with achieving what's best for our carers. So we can identify new ways of working. We spend a lot of time looking at innovation. We will shamelessly go look at all these other wonderful carers organisations and see what they're doing well, and then go and talk and see, will this suit our carers? Is this something that we could adopt? And we have a very quick turnaround time on anything we do. We work in a very asset-based way, so it's not looking at the deficit, making people feel bad. It's very much looking at what they have in the communities, what support they can already build on. And this is in the hope that we create a more sustainable support networks for our carers long after the intervention's finished, rather than the deficit-based model where we hold on to people and we over-support. So I'll touch on the data. So we have our own data analyst. So every programme that we run has our own data analyst. And this is invaluable, because what this allows us to do is really see what's working well, what isn't working well. And I'm talking about things like individual projects down to individual staff members' performance. And it really, really informs and shapes the things that we do. We can move budgets, we can move staffing according to our need. And the more data we have, the more we're learning month on month about our carers and what they're coming to us for. So we have a continuous improvement. So we have weekly performance meeting with our delivery partners, and then we have both formal and informal mechanisms to change. This last part's really exciting. We change things that don't work. So what we understand as an organisation and across our organisations is, if something's not working, why are we carrying on doing it? Because it's not written into a specification. We don't have to continue to do things that don't work. An example of this is when we first took on the contract, we have a particular delivery partner that was delivering our advice line, and then the delivery partners weren't performing, measures were put in place, and it became apparent that this was not going to change. So we actually transitioned from one delivery partner to another partner, and I'm really pleased to report that the relationship has now become really successful, and we are supporting carers in the best way possible. There we go, for next slide. Accountability. So we are accountable to our carers. So we have the transition group for the first year of the contract, who look at us and tell us what we're doing well. They hold us to account and they ask questions. This is in part facilitated by Carers Voice, our carer involvement group. We have partnership meetings, so we're involving carers at absolutely every level of our decision-making process. That's both strategic and decisions that are made on the ground. We are accountable to our carers on an individual basis through James, who you will talk to shortly. He audits the cases to make sure we're providing the highest quality care. And when it's identified that it isn't, then we put measures in place to make sure that there is improvement in whichever area we decide. We measure our carers' well-being on the outcome star, which they work through with the staff members, and also can sort of self-identify whether their well-being has improved or not. And again, as Bethany's mentioned, we also have the IPC independent evaluation, which has been invaluable in getting, they do interviews with carers who are currently in the service. And we've taken a lot from our first year report to say, actually, we're listening to what's been said in this report and we're going to make the changes necessary. Again, I've talked about the dedicated data analyst, and we have all sorts of data. We know phone data coming in, we know how people's time is being spent and so on. We're accountable at our board meetings, so we have monthly board meetings and we have monthly audit reports from our commissioners, and that's James. Management, we're accountable to staff for decisions too. We don't only consult and talk to our carers, we talk to our frontline staff, because at the end of the day, it's all well and good us sat in an office, but if it doesn't work for the staff on the ground, they're our eyes and ears, and they're the people who are delivering this service. So they're key to making sure we are doing what we say we do, doing what it says on the tin. So pop on to the next slide. I'm sorry if I'm talking very fast. I'm just aware of the time constraints we're under. So the learnings for year one, this isn't going to come as a surprise to absolutely anybody, COVID. Okay, so it's an anomaly year. It was a very difficult year to start a programme. I defy anyone to say different. Carers breaks, the uptake hasn't been what we expected, and a lot of this is down to COVID, the additional pressures on health and social care services. And what we did see is, as a result of the vaccine drives, we saw our referral numbers go through the roof as more people became aware that they were carers. What the data has told us in the first year of the programme is we need improved performance management of some individuals. We've got some fantastic staff who are delivering really high quality work and working at a rate that's really supportive to our carers. And then we have some that aren't. But what the data has allowed us to do is to identify those areas of weakness and to do something about it. We've also been able to, through the use of data, is reallocate resource. So, for example, we were running a 7-day-a-week advice line. And then when we get the telephone data in, actually carers aren't calling up on a Saturday afternoon and a Sunday. So what that has allowed us to do is move our staff resource so we have more staff on during the peak times during the week to allow more carers to get through, so things aren't being missed and carers are being spoken to within an appropriate time frame. It also allows us to see what carers are coming to us for, so then we can develop new resources and new programmes off the back of what we're learning about our carers year on year. So the next icon is a roller coaster, because I couldn't think of a more apt or appropriate icon to describe the first year of the programme. So I would love to come to you guys today and say everything's rosy, everything's amazing, but that I know not a single person would leave here believing anything that I'd said, because we all know it's not that straightforward. It's a huge change moving to this type of contract. We've lost staff. We've had a high staff turnover, particularly around performance management, when performance management conditions have been brought into play. We've had to win over the hearts and minds of both staff and carers. The levels of accountability that our delivery partners experience are something that they haven't previously experienced before. Now, the joy of working in this way, and I'm sorry I sound like an evangelist when it comes to this, is in a fee-for-service contract, so the old style contracts, when there's an issue, there is a potential that funding can be restricted, further impacting your ability to deliver. The way we do it is we actively encourage our delivery partners and our frontline staff to identify issues early on, so we can put the appropriate resource in place as soon as possible to try and solve those issues. So it's not a static funding system. We can actually put money in place where it's needed. For example, the advice line, we saw double the number of referrals coming through than we anticipated, but when based on the data from the previous services. So that's allowed us to go out, please go and employ the staff. Let's look at the systems and who we need to employ to make sure these carers come through in a timely manner. And we've done that across the board. So that's a really, really exciting part of this service. So the future, so we've learned a lot in year one, and the exciting things that we're bringing through is we are looking to create an online self-assessment for carers. This idea is in its infancy, and we're doing a lot of research with other organisations that have used this service. We work very closely with James to make sure everything's Care Act compliant. The other big key thing for us going into year two is the absolute gold standard of support for our carers. And where it's identified that they are not receiving gold standard, we need to look into that, and we put the appropriate provisions in place. We've also got some additional services that we're adding on. Mental health, it's not going to come as a shock to anybody that mental health is a key area in this. So we've now just employed a counsellor for a direct access counselling service for our carers in Norfolk. So they don't have to wait in the lengthy queues to access counselling services. In addition to this, we've actually brought in direct welfare and benefits support from Citizens Advice Bureau, which means, again, with the issues with universal credit, the cost of living rising, we can actually direct our carers. We can bypass waiting lists to make sure they receive the support they need in a timely manner. I'm going to hand over now, but just to say it's been an absolute pleasure. I could talk about this all day long, and if anybody does want us to come on and elaborate further, then please feel free to drop us a line. And as you can probably tell, I get very excited about this, and I'm happy to come and talk to anybody in more detail. So I'm going to hand over to the wonderful James now.
Thank you. That was so good, Victoria. So hi everyone, I'm James Stewart and I'm the Operational Business Lead for Norfolk County Council Adult Social Services. I'm a social worker by background, and I'm also a carer myself. And I'm coming to give you an overview of what this has, this SIB and the outcomes contract has meant in practice for Norfolk with our carers and our staff. So as we've alluded to, we did a lot of co-production with carers at the outset of this journey and during this journey. And we found out key themes from them about what their experience was like of accessing services and support in Norfolk as carers. They felt the system was incredibly complex and challenging to navigate, both carers and professionals from across the board, health and social care. They often weren't aware that they'd had an assessment. They didn't know what an assessment would involve. They didn't know what types of support they could access. So we really had to go back to the drawing board and look at all of that. And obviously with having the profile of the social impact bond, this enabled us to really levy it and look at how we could really support carers and take what they told us and what we'd learned into consideration and use that to help what we were doing. Also, we spent a lot of time working with staff across the board in health and social care, again, finding out from them what their experiences were like, what their understanding was. Staff often felt they lacked confidence. They didn't know what carers' rights were, how to deliver a good assessment. So we were really able to take that and use it. So from the back of that, we were able to develop training for our Norfolk County Council social care staff. We have done work with our new staff coming into the service as part of their induction to brief them on carers' rights, what support's available locally and nationally, plug and promote and engage them into Carers Matter Norfolk, so that when they do come across carers in their work day to day at the coalface, they know exactly where to signpost them to and what sort of support's available, so they can use that as a unique selling point to carers and encourage them to access that support. Also working with staff, we reviewed our assessment forms and used feedback from them to help amend and improve our assessment forms as well. And also in respect of our work with carers, one of the things we were really, really keen to do was to make sure that they remained as independent as possible and they were able to access advice, information and support as early on as possible as well. And what we found often when we were looking back at records is that carers had multiple contacts with a range of services and often weren't identified as a carer and therefore connected at the right point. And a lot of things could have been avoided had they have been. So again, we did some work building into our forms and our referral points to make sure that staff were prompted to check if someone's a carer, find out what their situation was like and look at how best to support them. So that really helped in that piece of work. And one of the other things that we did was we took on the tagline of #ThinkCarer and used that to feed out and look at engaging and promoting with our staff to remind everybody at every contact they have with somebody to check that they're a carer, see what's going on, and go from there, and make sure they're connected to the right support. Also as well, one of the things that we also looked at was our web pages to make sure that they were containing the correct information, and we overhauled them. We worked with carers and staff to think about how we wanted the information to be collated, to make sure again that carers knew if they were visiting our websites what they were entitled to, where they could go for that, to help streamline the pathways and make things less confusing and complex for them. And to also make sure that they had access to good information and advice and support at an earlier point. And to also make it really clear, we looked at our breaks offer as well, which we handed over to Carers Matter Norfolk to manage. We recognise that carers need access to regular breaks, and to look at how that was going to be delivered, speaking to carers about what would work for them, what they felt would be beneficial, and to use that in the work that we did with Carers Matter Norfolk and our staff. And also to ensure as well that staff knew how to deliver a good quality carers assessment, because again, looking at the work leading up to the SIB, there were examples where we did some really good practice, but it wasn't so good in other areas. So again, going back to the drawing board, rewriting our practice guidance for staff, making sure that when we work with Carers Matter Norfolk, their staff were trained up to deliver good quality carers assessments and know exactly how to approach it, the types of questions to ask, what carers' legal rights were, and to make sure that they were aware of all the services and support available as well, because we didn't want carers going to them and then them hitting a brick wall. So that was some of the things that we did with our carers and our staff during that time. And another area that we've worked on as well is regularly auditing the work completed by Carers Matter Norfolk. We've done regular audits throughout the first year. It was monthly to begin with, and then it's moved to bi-monthly. And we've seen some really good examples of innovative pieces of work, really good quality assessments. And when we have identified themes and trends, we've been able to react to them really quickly. So if certain themes have been identified in audits, we've then the following month delivered a bespoke training package to those staff to help feed into them where they need to improve, how to do that, and where to go to do that as well. In terms of Norfolk County Council's role in this, the legal duty for carers assessment still rests with Norfolk County Council. We've delegated that duty to Carers Matter Norfolk to deliver on our behalf. That said, our practitioners can still deliver carers assessments. So, for example, if a carer wants to have a carers assessment delivered by the local authority, they can absolutely request that, and we will deliver that on their behalf if their preference isn't to go to Carers Matter Norfolk. If there's complex family dynamics and we're doing a piece of work with the cared for and it's felt better to have a holistic in-house approach, then we'll do that. If the carer themselves is struggling to access the assessment process and engage and doesn't have anybody to support them through it, then they would have an assessment via Norfolk County Council with the input of an independent advocate. And also if there are safeguarding concerns, be it wider safeguarding concerns or concerns about the relationship with the carer and cared for, then if we were to be undertaking safeguarding inquiries and looking into it from that route, we would then undertake and deliver those carers assessments as a department and a local authority. So as you can see, we've had a really good first year. We've had really good numbers coming into the service, and a high majority of the referrals have come through from our frontline social care teams, which has been really good. And we've seen some really good examples of good work in between our frontline social care teams and Carers Matter Norfolk. But we've also done engagement with the acute hospitals, our community healthcare teams, GP surgeries, etc. as well, to promote the new offer and make sure that they're aware of where to signpost carers to as well. So on to the next slide, back over to Victoria, I believe. Or Luciana.
There we go. Sorry, I was on mute then. These are actually just appendix slides, so I'm happy to move over to questions. I appreciate that that we've all talked quite a lot, and I'm sure there's a million questions in the chat that we'd be happy to answer. And if they can't be answered now, I appreciate we're very short on time. Then I think there's facility there for us to be able to come back to everybody to answer those questions individually as well.
Brilliant. Thank you all so much. That was a really comprehensive and fast-moving presentation. You've really crammed loads into it. There are quite a lot of fairly complex questions in the chat box. So I guess I should say firstly that we will share the slides from today afterwards, but what we will also do is send a list of the questions to the team as well. So anything that we don't manage to pick up within this session, hopefully we will pick up by doing that, because I would imagine some of the things that you've been asked will need more than a minute or so to answer. But there are a few things that can probably be answered fairly quickly that have come up in the later questions. One was, is this offer around young carers as well as adult carers, or is it just an adult social care focused piece of work?
Yeah, so this offer is only for adult carers of adults. There is a separate offer commissioned for our young carers, although the assessments for young carers are kept in-house, so Norfolk County Council does those. There's also a separate offer for parent carers. The split is simply because adult carers for adults are commissioned by the responsibility of our adult carer service in Norfolk, and then young carers and parent carers are commissioned by our children's services offer.
Fab, thanks. Kate, right at the beginning, had asked, were outcomes set at the start of the piece of work to achieve, and what were they?
I think perhaps we've covered those. So the outcomes are obviously to reduce carer breakdown, which is number one. The next one is to identify new carers coming through. And the next one is to improve carer well-being. So this is measured, we take the baseline when we first start engaging with our carers, and then we follow that up at 6 months and 12 months. So we check in on their well-being, but also to see whether they've sustained their role. And just to answer another question while it's popped up, we categorise our carer breakdown, the relationship breakdown, by whether it was avoidable or unavoidable. So sometimes if a cared for or the carer themselves passes away, it's an unavoidable breakdown. And then we have avoidable breakdown. So we can go back and say, well, has this relationship still broken down? And then we go back and relook at that case to investigate, why is that broken down? And is there anything that we could have done as a service that could have mitigated that? I hope that briefly answers that question.
That's far briefer than I expected you to be able to answer that, which is why I hadn't asked it. Very good. Interesting question from Kirsten as well about which department holds the Life Chances Fund and what's the criteria like for accessing it?
Yeah, so it's okay, Lucy can do this one.
I'm happy to answer. Yeah, so is the Department of Culture, Media and Sports, DCMS. They have the Center for Outcomes, I think is the name within them. The Life Chances Fund is no longer a fund that you can apply for, unfortunately, so it finished a few months ago, sadly. There has been a number of these funds, and there might be others in the future, I'm not sure. Normally, the typical criteria for applying has been you can apply as either a delivery partner organization or as a commissioning organization. You need to just have normally they have requirements about the type of services. It's generally all around social services and helping people improve their lives and well-being. And I guess the criteria has been that the services commission on outcomes, and the idea behind it was to promote this way of commissioning across the UK. That's why the top-up was there for. Brilliant,
thank you. I know that there are loads more questions, and another one's just popped up from Emma as well. So we will collate those and send you to them as a team if you'd be happy to answer those for us. But I think what's been really obvious is that you've sparked a huge amount of enthusiasm for a very different way of working. And certainly for me, from listening to you, just hearing about that flexibility and approach is really exciting. You know, the idea of setting outcomes and then actually looking at how you can creatively meet them rather than setting out a plan of work and then sort of almost assuming an outcome is really quite exciting, and I think really helpful, actually, because I think if there's anything that we know about the world of unpaid carers, it's that it is really unpredictable. And so having a way of working that enables you to take that flexible approach feels really healthy and sensible for me, and really good in terms of learning about what will be sustainable and commissioning in a way that will promote that sustainability and continuity for carers. I think one of the big issues we've seen over the last few years is this year-on-year commissioning cycle that we've had forever and a day across health and social care, which particularly when you're working with some quite small organisations across voluntary sector and other organisations is really unstable and unhelpful for carers and can undermine their trust. So Jodie, let me hand back to you to do a final thank you and summary, and then we'll say goodbye.
Thank you, and thank you to Vicky, Lucia, Bethany and James. It was a really innovative presentation. I, like Jen, really like the flexibility of that approach, and quality improvement, all improvement is actually, you don't know what the journey is, but you have an idea of what that vision, and I think the outcomes-based model really does look at what is the best vision for carers, and actually we don't need to know how to get there because we'll learn that as we do the journey. So I think it's great, and really looking forward to the next 4 years of the contract as it goes ahead and see what else you develop. So thank you for your time, and thank you to everybody for joining this the monthly lunch. I'm merging my words. Thanks very much again.
Thank you so much, everyone. Brilliant presentation. It's definitely got me thinking, and hopefully we will see many of you again and more still on the 23rd of March for our next lunch or lunchly and learn, whichever you prefer. It can be a lunch or a lunchly. Thanks, everyone. Take care and enjoy the rest of your day. Bye.
Thank you.
Thank you very much.
Thank you.